In case of a severe case of उसके पहले जो हमारा नंबर सिस्टम था वो हम विदिन 24 आवर्स उसका
वॉल्यूम बंद करो।
Namaste all. It gives me an immense pleasure in welcoming you. I'm Dr. Pratibha, working as clinical microbiologist and member of infection control team in Apollo Hospital's Jubilee Hills. This week is observed as International Infection Prevention Week, starting from 16th to 22nd of this month. International Infection Prevention Week was established in the year 1986, aims to shine light on infection prevention and control every year. So theme for this year is The Future is Infection Prevention, 50 years of infection prevention. As part of this, we Apollo Hospitals have organized a series of educational sessions. We are starting with today's session. It is today's talk is by Dr. Rajkumar. He is a consultant in critical care medicine. He is an intensivist working in the surgical intensive care unit at Apollo Hospitals, Jubilee Hills. He will be talking, his talk will be on overview of infection control practices in intensive care units. Audience can drop their questions in the drop box and it will be addressed at the end of the session. Feedback form will also be shared in the chat box at the end of the session. Please give your feedback. Thank you.
Hi, thank you Pratibha Madam for the kind words of introduction. I'm Dr. Rajkumar Jupally, working presently as a consultant intensivist at Apollo Hospital Jubilee Hills in surgical intensive care unit. And shortly I will be sharing my screen regarding the presentation. Yeah, I believe my screen is visible to you. So today we'll discuss regarding an overview of infection control practices being followed in an intensive care units. So why we need to discuss regarding the infection control measures? It is an utmost importance like in the care of the patient, especially regarding the safety mechanism in the intensive care unit. Joint Commission International has identified its importance and included the infection control measures in the International Patient Safety Goals 5. The hospital-acquired infections must be differentiated from the community-acquired infection, as it is caused by more virulent and pathogenic bacteria. It is very difficult to treat such infections, and the infections might need a broad spectrum antibiotics, including dual antibiotics and triple antibiotics, ultimately leading to cost burden to the patient. It not only increases the cost of the treatment, but also increases the overall length of the stay in the hospital, more so in the ICU, and also might lead to mortality of the patient. That's the reason we have to concentrate not only on the technical aspects of the treatment, but also the intensivist should work as a team to decrease the infection rate in their particular ICU. Coming back to the evidence, even the SENIC project says that, which stands for Study on the Efficacy of Nosocomial Infection Control, which says that if there is a well-organized infection surveillance and control program in your particular hospital, then approximately 32% of the infections can be reduced, thereby decreasing the length of the stay and mortality in ICU. This is the evidence which was being published way back in 1980s. The essential components of infection control measures in the ICU are, it starts from the designing the ICU. When the hospital is being constructed, and especially coming back to the ICUs, the design of the ICU should be taken care by the team, like the infection control team of the hospital, like proper bed spacing between the two beds, and essential effective air circulations, provisions for positive pressure ventilation rooms and negative pressure ventilation rooms, and proper contact precautions needs to be followed in their ICU. So whenever you are designing in the ICU, you should keep in the back of the mind regarding the infection control measures being practiced in that particular ICU. Not only in the designing in the ICU, the second point you should re-emphasize on the standard precautions what we follow in the ICU, like hand hygiene, hand rub, like PPEs, personal protective equipment, and henceforth. The third point is the care bundles approach, which we would discuss in detail. And the fourth point is isolating patients with multi-drug resistance and pan-drug resistant infection and other communicable diseases to prevent cross-transmission from one patient to other patient. ICU patients are very fragile and immunocompromised. You should ensure the proper isolation practices for the patients with multi-drug resistant infections and other communicable diseases. Cleaning as well as disinfection of your like environment in the ICU should be like closely followed by the intensivist. He should daily discuss with his housekeeping team as well as the microbiology team regarding proper disinfection of the regular touch surfaces in their ICU. Appropriate staffing ratios also needs to be considered, and regular staff education needs to be done regarding the bundle care approaches as well as the infection control practices. The final point is improvising the reporting and surveilling system. In few months, there might be like increased CLABSI or QATI rates, but you should not hesitate in reporting the like infection rates in your ICU. If you report the infection rates properly to the team, then the team might intervene, do a root cause analysis of why the cases of infection rates have increased in that particular month, and come up with a solution like reiterating the importance of staff education and other practices where we are going wrong, and then we can do a surveillance system so that we can improve our decrease the cross infection among the ICU. Coming back to the basics regarding the chain of transmission. This might be appear like very basic, but this is the most important crux of our slide. You have to break this chain of transmission at the 6 points. there are 6 vulnerable points in this chain of transmission, like either infectious agent, it can be a bacteria, it can be a virus, appropriate diagnosis and identifying the pathogenic organism at the correct time might also help in breaking this chain of transmission, identifying the source, whether it is from the patient or it is from the environment. Like there can be a breakout of Acinetobacter infection, or there can be a breakout of Burkholderia infection in your ICU. So identify the source of infection, whether it is from the patient or whether it is from the environment or whether it is from the dialysate fluid, and do proper environmental sanitation, disinfection to break this chain of survival. Coming to the third route where you need to concentrate is the exit route of this pathogenic bacteria, whether it is being exiting through the aerosol route, droplet route. So try to control this by properly following the hand washing, hand rub, control of the aerosol sprays and all. The fourth chain is means of transmission. The same thing, whether by direct contact, inhalational or airborne route. The portal of entry, like from the mucous membranes, respiratory tract, broken skin, especially in surgical ICUs, there will be a lot of drains. The drains can be using a lot. So you need to see that these drains are properly secured. There is no environmental contamination through this. And if you properly do your environmental disinfection, then you can break the chain of infection here. And the susceptible host, if there is a susceptible host, following the isolating the patient to the positive pressure or negative pressure appropriate to the requirement of patient might help in breaking the chain of infection. Coming back to our basic practices, this is the most important slide I want to say today. You need to follow the 5 movements of hand hygiene in your ICU, like before touching the patient, before clean by aseptic procedures like insertion of central line, insertion of a Foley catheter. Most of us forget to do an hand washing before inserting a Foley's catheter. Please ensure that Foley's catheter insertion is a sterile practice method. So always do a hand wash before doing such procedures. So never forget to do a hand hygiene before touching a patient and before doing a clean by aseptic procedure. And after body fluid exposure risk, suppose if the patient is on intercostal drain or a Romovac drain, before and after charging the patient, you might think that just charging the drain might not contaminate your hands, but do wash your hands or do an hand rub after touching these drains or Romovac drains and all, and ICDs also. After touching a patient, whenever you clinically examine the patient, auscultate the patient, touch the patient for temperature, like looking at the pulse rate, definitely do a hand rub. And if it is visibly contaminated, do a hand wash also after touching the patient. And after touching the patient surroundings, like you might have touch the patient areas, like in the cupboard, in the stethoscope at the bedside of the patient, torch at the bedside of the patient. Do hand rub after doing touching the patient surroundings. So definitely follow this 5 movements of hand hygiene to break the chain of infection, thereby preventing the spread of infection from one patient to other patient in ICU. How to hand rub? See, most of us are practicing hand rub after the COVID pandemic, but hand rub should be done appropriately by following all the steps. Hand rub should be done approximately 20 to 30 seconds. Take a palmful of the product, that is the HD what we commonly used, covering all the surfaces. Rub hands palm to palm, then right palm over the left dorsum with interlaced fingers and vice versa. Palm to palm with finger interlaced, and back of fingers to opposing palms with fingers interlocked. Rotational rubbing of left thumb clasped in right palm and vice versa. Rotational rubbing backwards and forwards with clasped fingers of right hand in left palm and vice versa. And let this solution dry in your hands. Whenever the solution is wet, that is not effective. So allow this solution to dry in your hands, and then only your hands are safe to go to the other patient. So definitely practice this hand rub. But when your hands are visibly soiled, suppose if you have touched a patient and there are some blood stains on your hand, not only blood stains, but if there are certain like oozing from the patient, like bed sore oozing or oozing from the drain, touching the ICD side, changing the dressing, then your hands are visibly soiled. So rather than doing a hand rub, properly follow the hand wash techniques. Go to your sink in your ICU in the provided area. It should be done for 40 to 60 seconds with enough soap and following all the steps as described previously in the hand rub. But at the end of the like hand washing, use a dry hand towel, or you use your appropriate tissue paper to make your hands dry, and then only move to the other patient. So hand rub and hand wash should be done as a standard precautions measures in your ICU. Coming to the concept of a bundle care approach in an ICU. Bundles are nothing but to say it in a simpler way, they are a group of intervention which when done togetherly, which might lead to a good outcome. So what I want to reiterate is that these are the several elements which have to be done simultaneously, and it has to be done consistently to get a better outcome, greater quality than elements done independently. That means that you have to do all the elements together rather than doing it independently. That means that either one point is not enough to break the chain of infection. You have to do all the practices together to break this chain of infection. And systems must ensure that all elements are applied to the all the patients. Today we will discuss regarding 4 bundles in detail: the ventilator associated pneumonia bundle, central line bloodstream infection bundle, catheter associated urinary tract infection bundle, and the surgical safety bundle. This is the form what we practice in our ICU. Whenever an intensivist or a anesthetist is going to insert a line, we have a form for it: central line insertion practices adherence bundle. It will be filled by the concerned nurse who is at bedside, who is going to assist the doctor for the central line insertion. So it includes the standard IPSG-1 data, where we have to identify the patient and label in the appropriate column. Then after IPSG-1, the nurse documents the date and time of insertion for future reference, so to calculate the days of central lines. And the insertion site should be appropriately ticked here. If the preferred line, as you can see here, the first is the subclavian. Always prefer the subclavian or the internal jugular vein of insertion to decrease the rate of collapse. And if the site is not appropriate, suppose if there is a dialysis catheter on the right internal jugular vein, and suppose if there is a EJV, the external jugular vein, on the left side of the neck, then in some scenarios, you might be forced to use the femoral route. So whenever you are using another route like subclavian or internal jugular, so whenever you are using a femoral route, try to specify the reason why you are going for an alternative route rather than a subclavian or an internal jugular vein route. And the next point is, did this insertion attempt result in a successful central line placement? So if the number of insertion attempts increase, then there is a chance of complications, like there can be a hematoma formation, so that you can monitor the patient in the next few hours. And you should follow the maximum sterile barriers precautions like mask, large sterile drape, sterile gloves, sterile gowns, and the patient. The most important point is the patient body should be covered by a sterile drape from head to toe, and there should be appropriate skin preparation with the chlorhexidine gluconate or povidone iodine. We prefer chlorhexidine gluconate. And if the skin preparation was not chlorhexidine, then you should document was there any contraindication to chlorhexidine. Okay, and all guidewires and stillets are removed. It is for the safety of the patient, and all the flushing of the lines with sterile and replaced with sterile clamps, and sterile transparent dressing is applied or not. If you follow this, all the precautions, all the central line insertion practices, then the chances of central line infection during the insertion might decrease. This is the maintenance bundle, CLBSA prevention bundles. You should use the maximal, as discussed previously, maximal barrier precaution during insertion, chlorhexidine skin antisepsis, optimal catheter site selection, transparent dressing, daily review of the patient, whether the central line is needed. If it is not needed, and if you can secure a peripheral line, so try to pull out the line as early as you can, so that you can prevent the rate of infection. And this maintenance bundle has to be signed by the nurse daily in each shift, and appropriate measures have to be taken to decrease the number of catheter associated like bloodstream infection and the number of days on the line. This is the SSI tracking sheet, which needs to be followed, especially in surgical ICUs as well as in the wards. The nurse at bedside needs to track all these points from postoperative day 2, like fever, whether this patient had any fever less than 100.4 for 3 readings within 24 hours, whether there is any purulent discharge from the surgical site, or if there is any disproportionate pain. Normally, the pain in the postoperative period is common, but if there is any disproportionate pain to the surgery, then definitely it is a possibility of surgical site infection, tenderness by localized swelling, and if the points are appropriate, then the nurse should question whether the cultures have been sent from the surgical site or not. After sending the cultures, if the reports are received, you need to document here. Along all this, if there is a change in TLC from the baseline, then also you need to tick this appropriate points. If you can observe the sheet in the last column, not only the nurse at bedside or the in charge of that particular ICU signs here, but also there is a signature of infection control nurse. Some of the patients, like some of the units, might be hesitant to report their surgical site infection. That's the reason infection control nurse is also like involved in this surgical site infection tracking sheet, so that she can monitor the patients appropriately and see that whatever good can be done, like timely antibiotics, timely sending cultures from the surgical site, is implemented in that particular unit. The next one is QATI bundle, catheter associated urinary tract infection bundle. As I reiterated initially, hand hygiene, that is hand wash, should be done before inserting a Foley's catheter. Strict aseptic precautions like appropriate covering the patients while insertion, sterile drapings, appropriate holding the catheter, like fixing the catheter in proper place. Always the Euro bag should be below the patient level. Follow closed drainage system, and daily review the patient for removal of the catheter, like if the catheter is necessary or not. Most of the patient, like especially in the surgical ICUs, the catheter might be inserted for a long duration surgery. Previously the patient might be normal, like 40-year-old going for a surgery, long duration surgery, then the catheter might be essential. But always on POD2 or POD3, whenever the patient has started to mobilize, try to remove the catheter as far as possible, because removing the catheter might decrease the QATI rate. But be careful whenever you're pulling out the catheters in like old age patients. There might be like prostatic hypertrophy. There might be issues of urinary hesitancy in such patients. So always like discuss with your teams, like urology team, surgical team, and always ensure the catheter appropriateness to your patient, and see that this patient catheter is removed as early as possible whenever the clinically indicated. This is the QATI maintenance bundle. This also is signed by the nurse at the bedside in each shift, ensuring the all points have been followed, like hand hygiene performed before hand hygiene performed and aseptic technique followed, assessment for the need of the catheter care given, urinary catheter has been continuously connected to bag and no kinks. Usually what happens is the fifth point is not taken care of properly in ICUs, especially during the transport. Whenever the patient is being transported to CT scan or MRI scan, make sure that this urobag is not in the bed, and it is always below the level of the waist but not on the floor. There is always a chance whenever you're shifting the patient for investigation, the whatever urine is there in the bag and the tube can backflow into the bladder, thereby resulting in cystitis and also in the infection of the urinary tract, which might result in sepsis and septic shock in some of the patients. And the last bundle is the ventilator associated pneumonia bundles. You need to properly elevate the patient at the head end to prevent aspiration, micro aspiration, oral chlorhexidine mouthwash, closed suction system, and stress ulcer prophylaxis, DVT prophylaxis, sedation, vacation appropriately being followed in your ICU, early extubations, and hand wash before doing suctioning and after doing suctioning of the patient. The same thing depicted here. Only thing what I want to stress here is the suctioning part. The suctioning should be done as and when required only. If you do very aggressive suction in the some of the patient, it might lead to tracheitis, especially ventilator associated tracheobronchitis. What happens is you will create a lot of rough areas in the trachea that might in turn lead to colonization of the bacteria, and it lead to tracheitis and ultimately leading to ventilator associated pneumonia. So always try to keep the head end elevated to prevent the aspiration, which is the most important thing, and oral care. Oral care from the nursing side, usually it is good when the patient is not intubated, but when the patient is on ventilator, the oral care is the most important thing you have to do. Try to remove the airway if appropriate. If the patient is sedated and paralyzed, if the patient is not biting the tube, if the patient there is no dysynchrony on the ventilator, try to remove the oral airway, then properly suck out all the secretions in the mouth, then do a chlorhexidine mouthwash. What frequently I see is the junior nurse at the bedside might be hesitant to remove this oral airway, thereby leading to retaining of the secretions in the oral cavity. And ultimately, even if you do a chlorhexidine mouthwash on the teeth of the patient, it will not result in a better clinical outcome. Whatever secretions are there in the oropharynx and the nasopharynx will ultimately trickle down into the subglottic region, and then will lead to microaspiration and ultimately to ventilator associated pneumonia. So please give a proper oral care in the patients on ventilator. Take help of the doctor, especially in the morning times. If you feel that this patient has not received proper oral care, don't hesitate to involve your doctor. Ask the intensivist to do a proper oral airway, and if and when required, we sometimes use the laryngoscope also to clear out all the secretions and see that this oral cavity is taken care of properly. Yes, we have done with the bundles. Now in our hospital, we follow certain precautions, and each precautions are color coded for easy reference for the nursing staff as well as also to the other staff who are taking care of this patient. So first we will discuss regarding the droplet precautions, which has to be followed in swine flu, the H1N1 influenza, mumps, SARS-CoV-2 and diphtheria. Wash your hands before touching the patient and after touching the patient, as we discussed previously. Wear appropriate PPE, surgical masks. Try to treat this patient in a single room, and the environmental cleaning. This card has to be kept at the bedside, and it should be visible to all the treating teams like dietitian, physiotherapy team, nursing team, and doctors. So and especially the housekeeping staff also. So try to keep this card in an area where everyone could see it and it is easily visualized. The second one is the airborne precaution. We follow this airborne precautions in Mycobacterium tuberculosis, measles, and chickenpox. where we follow all the techniques as discussed previously, but we wear an N95 respirator mask whenever we are treating such patients. We keep these patients in negative pressure rooms only, and environmental cleaning as discussed previously, and ensure that doors remain always closed. The third most important thing for an intensivist, especially in a medical ICU, is the contact precautions. Most of our patients, especially if we receive the patient from outside units, the patient might be harboring different multi-drug resistant organisms already before coming to your hospital. So to prevent the spread of infection from one patient to other patient in your ICU, especially to some patient who is not infective previously, like the patient might be suffering with only acute pancreatitis, but if you keep some patient beside this patient, like a very infective patient with a lot of bed sores, harboring MDR, some Klebsiella organism, it might lead to spread of this infection to the other patient and increasing the stay of the length of the in ICU. So follow these contact precautions in multi-drug resistant organisms, like washing hands appropriately, wear personal protective equipment, wear normal masks, try to nurse this patient in single room if available. If single room is not available, cohort these patients to a different place, like in your ICU, cohort these patients harboring multi-drug resistant organisms, and environmental cleaning to be followed appropriately. Comparing all the precautions like contact, droplet, and airborne precautions, the point to be noted here is airborne precautions, the patient should be nursed only in the negative pressure room, and in airborne precautions, the door should be closed all the times. It cannot be kept open. In droplet and contact precautions, it can be kept open if required, but in airborne precautions, it has to be closed at all times. And the equipment cleaning, try to educate your housekeeping staff, try to involve your nursing housekeeping supervisors for the dedicated equipment disinfection. Try to refer to your documents how to clean these equipments in certain particular conditions like contact and droplet precautions, and ensure that this equipment are cleaned properly and environmental cleaning is followed as per the protocol. And mask, especially in airborne precautions, you have to use N95 mask, which is appropriately sized and appropriately fitted to the face of the healthcare worker, and rest all should be as per like standard precaution. Criteria for discontinuing isolation precautions, like criteria for de-isolation are disease specific and vary from institutional protocol to different institutions. Duration of isolation precautions for duration of infectivity, theoretically or confirmed, should be followed. For most infection diseases, this duration reflects known patterns of persistence and shedding of infectious agents. Like different diseases might have different shedding rates, like 1 week, 3 days, and 10 days. For other diseases, you should follow your state laws and regulations. In immunocompromised patients, the viral shedding can persist for prolonged periods of time. Therefore, the duration of contact and droplet precautions might be prolonged for many weeks. Thank you. Thank you for patient listening, and thank you.
Audience can post their questions in the chat box. Okay. Thank you, Dr. Rajkumar, for that wonderful presentation. Audience will agree to it for this elaborative and useful session. It was quite useful. Now, talking about the prevention of infection in ICUs, yes, it is a teamwork. Teamwork has to be there to prevent the infections. It has to be a teamwork from the side of intensivist or the unit in charge and the infection control team. It is not a single person's responsibility. Unless we do the teamwork, infections cannot be prevented. And already, if you look at the patients in the ICU, already they are immunocompromised. They are on multiple lines. So unless we follow the infection prevention practices or infection control practices, prevention of infection will be it will be quite challenging. Now coming to the talk, sir has very told elaboratively. One thing I agree to is it will begin with the engineering control from the beginning, from where the hospital construction has started. So engineering control plays a major role. So whenever you're constructing your hospital, you should see to it that your ICU infection control team inputs are taken into it. And now are there any audience who have posted the questions? We'll wait for some more time. We'll wait for audience to post their questions.
Yeah, we could see one question from Dr. Niyati Sakarwal regarding surgical site infection. What we follow. So what we follow is definitely it is a practical point, especially in arthritis, and similarly sorry for technical issues. Usually like in surgical site infections, especially laparoscopic surgeries, the trend towards daycare surgeries is on rise. So what we follow here in Apollo Hospital Jubilee Hills is that we monitor the patient, like even if the at the time of patient discharge, if there are no signs of infection, what we do is we take the list of such patients and we track them, like we call them at frequent intervals, so that if any signs of infections are there, they will report it to our ICNs. ICNs take the responsibility of noting such patients and call them and follow whatever points we have discussed in the SSI tracking sheet. This is being followed not only in daycare surgeries, but also for the other patients like CABGs also. That helps in identifying the infection early and guiding the patients and the family to the healthcare settings at the appropriate time for the initiation of antibiotics.
Thank you all. Thank you all. This is the end of the session. We have organized such topics for entire week. We'll be sharing the link on daily basis. So this is the end of the session. Thank you.
Namaste all. I would like to express my gratitude to everyone who took the time to attend this today's session. I think you all have learned something interesting today. I want to let you all know the highly anticipated and the most awaiting 9th International Patient Safety Conference will be held on 13th and 14th February 2023 at Taj Place, New Delhi. I request everyone to visit our website www.patientsafety.co.in for furthermore updates about this 9th International Patient Safety Conference. Here I would like to show a short intro video about that. I hope you like this. Thank you. Hope to see you all for tomorrow's session on infection prevention measures in special settings, that is transplant unit by Dr. Venkat Ramesh, the ID specialist. Thank you and stay tuned.